As we devolved, nobody knew how much it costs to run health. No county knew what it takes to run a health department.
The issues of development of the annual work plan was not there. The issue of development of the annual performance review was not there.
What we have been lacking and which the HP has supported has been support on realistic budgeting.
We were so happy when we received the microscope, because now at least all patients with malaria can be tracked and treated well.
Before HP Plus, it was a blind, let me say, a blinded effort. People did not exactly know how much it cost, and so we were just given money. HP Plus also has helped us analyze our budgets. This program-based budgeting, where is the money going to? How much is curative getting? How much is preventive getting? How much is general administration? Yes, unfortunately, most of our money goes to PE, personal emolument. Actually, over 60% of the amount goes to personal emolument. And development, of course, we look at the formula of having to get 30% going to development. So you are left with very little amount of money to do operation and maintenance component. And that is where the bulk of our service delivery is. We buy drugs using that money. We buy fuel, we buy food for the patients. So even an O&M of, let's say, 400 million, in just 1.5 quarters, it will be over.
5 years ago, I think our allocation was about 23%. A lot of work has gone in, a lot of advocacy, a lot of capacity building, and right now we are doing an average of 28%.
For Busia, as of now, the county government has allowed us to execute 30% of its total budget. At least we are doing at around 30%, slightly above 2.5 billion, above 2 billion shillings.
Sometime last year, when we were having an engagement with the HP Plus, we managed to be taken through an analysis of the vote book and the standard chart of accounts. I'm happy even the malaria focal person, the county malaria focal person, after our meeting, he was able to go to the budget document. He secured his malaria funding and they were able to buy microscopes.
So we noticed that the percentage of facilities that were doing microscopy were very few. So of the 3 million, we said we are not going to do anything else. We are going to do microscopy first, so that we have got 13 facilities that are not doing microscopy to start doing microscopy.
We were able to test or to capture patients who had malaria, Plasmodium malariae and Plasmodium ovale. And so I think now the clinician could treat the correct thing. Because before they were missing it out, because MRDT cannot detect the 2 Plasmodium species. And also at the same time, with microscopy, we normally do quantification. So it is easier to detect a patient with severe malaria through quantification. And also you can do a follow-up by quantifying to assess whether this patient is responding to the drug that has been given or he's not responding.
So that training opened our eyes. We've always been losing our money because we're not executing the budget the way it's supposed to. After if you go to the accountant, he'll ask you, okay, fine, your money is there in the budget. How are you supposed to utilize it? How are you charging it? Which code are you going to use to charge this money?
If you looked at our budgets previously, we used to concentrate so much on the curative side. You could only look at how much do you allocate for drugs, how much do you allocate for buying of equipment. But thanks to their effort, we were able to see the need. We put these needs into the budget. We managed to generate evidence based on those particular interventions. And right now, if you look at our budget document, you'll find a lot of programmatic, a lot of support on preventive interventions, HIV, malaria, eye, RIMCA, non-communicable diseases, and many others.